Mr. Smith, we are going to have rounds, bedside rounds. We do them here in the room, and what that consists of is the doctor, dietitian, pharmacist, respiratory therapist, physical therapist, and chaplain, case manager. Anybody taking care of your wife will come into the room. There's usually about 9 to 10 people, and we discuss goals of care for her. It's usually very quick, about 3 to 5 minutes. Everybody comes in, we explain metrics, how to keep, making sure we're keeping her safe and doing everything right by her. There'll be a small moment at the end where the doctor will recap everything for you. However, it's very fast moving and we have to cover all the patients in the unit. So if you have any questions, you can write them down. And then as soon as rounds are over, usually the doctor will have some time, he can come back and address any concerns that you have.
Okay, thank you.
Alrighty, no problem.
All disciplines should reference the MDR tool during rounds to ensure we are meeting important metrics, staying on topic, and including the whole team.
Is everyone ready for multidisciplinary rounds this morning?
Yes.
Yeah.
All right, hi, I'm Candace. I'm the charge nurse today. We're all piling in your rooms to do rounds, okay? We're going to discuss your wife's care, all right?
Okay, everyone. This is Miss Smith, and this is her husband, Mr. Smith. Ms. Smith was admitted with CHF exacerbation back on May 1st. She's had a very complicated ICU stay. She was diagnosed with cardiogenic shock back on May 18th and was started on milrinone and CRT. She was intubated overnight for respiratory failure, and a follow-up echo is planned for today. She has a Swan-Ganz catheter for hemodynamic monitoring and a PICC line to provide more access for vasoactive agents. She also has a femoral vas cath for CRT because we couldn't obtain access anywhere else. She has a radial A line because she's on multiple pressors and a Foley that was placed last night for retention. She has a positive sepsis screen today due to a white count of 24 and her temperature was 97. Her lactic was 1.2. She's currently on milrinone at 0.375, levo at 1, vaso at 0.04, low intensity heparin for AFib, and amio for rate control at 1. Hemodynamics are stable on this support. We're pulling negative 100 an hour on CRT. Her wedge is 20 and her vent settings are stable. Pain is controlled with a fentanyl drip at 1. Her RAS is currently at goal at -1 and propofol is on 30. We're unable to assess CAM-ICU at the time. She's not restrained and her skin is intact.
The patient presented was very complex, but the RN only shared the most recent and most important information. If you have concerns for your patient or orders that need to be placed, such as restraint orders or consults, please be sure to request that they be entered in real time by the APP using the mobile workstation.
Okay, respiratory.
The patient is on assist control volume control at a tidal volume of 400, which is 8 cc's per kg, a rate of 16, a PEEP of 5 at 80% FiO2. She was intubated for respiratory failure last night. The ABG prior to intubation was 7.18, 68, 50, and 20, and -6. ABG this morning was 7.35, 48, 115, 21, and -1. No coordinated SBT and SAT due to recent intubation. We are in compliance with the VIE bundle.
Okay, and I'll order the sepsis bundle, but we're going to hold off on giving IV fluids because she's got a wedge of 20.
All right, okay, pharmacy.
Her heparin drip covers her DVT prophylaxis. Can we add IV protonics for PD?
Yeah, we can. I'll order that.
Okay, and then since she'll be starting on vancomycin, would you like for us to renally dose this in?
That'd be great.
Okay, and any meds that I can change from PO to IV, I'll do so.
The charge nurse should prompt the other disciplines to ensure that the conversation flows in order and on time. After the RN, RT, and pharmacist give input, the charge nurse can ask the team if there are any other concerns. At this time, case management, dietary, PT, and speech can provide their input.
Okay, does anyone else have any concerns or questions about this patient?
Can we start tube feeding for nutrition support?
Sounds like a great plan.
Okay, I'll put that consult in.
I'm from PT. I saw that we had a consult in for her, but since she's on the vent, we'll wait until she's more stable. Come back.
All right, thank you. Dr. Klein, can you please summarize the plan for today?
Yeah, Mr. Smith, your wife is on the ventilator right now. She appears to have a lot of fluid on her lungs, and with that, we're going to use the dialysis machine to draw out some of that fluid. Anytime you get the fluid on the lungs, there's always a concern the heart might be affected, so we're going to do an ultrasound or echocardiogram of the heart today.
Okay.
In addition, our labs and our vitals starting to sound like she might be brewing an infection, so we're going to get some blood cultures. We'll start some broad spectrum antibiotics to treat that. In addition, we're going to get some tube feeding on board to make sure her nutritional status stays up to date and that she gets better.
Thank you.
All right, anybody have any questions? Awesome job. All right.
Thank you.
Thank you.
And if you have any questions after rounds, the doctor will be back to address those.
Okay, thank you.
After the physician provides the 1-minute recap, the families may voice their concerns, but it is the responsibility of the physician and/or charge nurse to redirect the family if questions become lengthy. He or she should reassure the patient and family that their questions will be answered after rounds.